Right. Good morning, good afternoon, good evening, wherever you are watching. Welcome to ENRIPARC's first international online networking event, and this is today the third session in this event. I will just say a few words of welcome and an introduction, and then I will hand over to today's speaker. So first of all, about this session, it's being recorded, so we can provide the video or links to the video later on to other participants. But we will stop the recording before the question and answers section. So it's mainly the talk that is being recorded. I have a little poll I want to run so I can hear a little bit about who joins these sessions, and then I'll talk to you about the event Padlet and ways of being involved, and then we'll have the talk. One reason for this networking event is that we want to engage people and we want your contribution and your thoughts and your ideas. So the whole week, the question is, well, there are a number of questions about psychosocial adjustment and rehabilitation that we're trying to answer. And if you go to the page 8 on your delegate pack, there's a link to an online Padlet tool with 6 questions that you might want to look at and maybe give us your thoughts about. So you can write your answers directly into this Padlet. On Thursday, we have a facilitated session where we actually discuss these questions and try to pull together what are the answers to these questions. So I hope to see you there. And finally, ways of being involved. I mean, generally, membership is for the moment only through the LinkedIn group. If you're not already a member, please join. Look at the group and request membership. And it's everybody's welcome to be a member. If you want to be more actively involved, you could either become a member of the Lived Experience group. If that is of interest to you, please contact Steph Killich. Her email address is down below. You can also contact us through the LinkedIn group. If you are a clinician or researcher and you would like to be a member of the leadership board, you can contact me. Or if you are interested in research collaborations or anything else, please feel free to contact me. So then I will just launch the poll. Here we are. Oh no, sorry, I just realized it's not working. Right, we will then proceed to the talk. I'll just remove my screen sharing. There you go. And then I will hand over to Simon van Rysewyk, who will talk about the meaning of coping with chronic pain. So.
Thank you, Liz, for that warm welcome, and hello, everybody. Good morning, good evening. Hello from sunny Sydney. My name is Simon van Rysewyk, and I'll be presenting today on the meaning of coping with chronic pain. So first, let me share my screen. Just give me 1 second. Okay, let me see. Can you see that top screen, everybody?
Yes, Simon, can you do it in presenter mode? We see the whole. Yes, yeah, well, the whole screen.
Okay, let's try that again. There we go. Okay, I think we are ready now.
That's fantastic. Thank you.
Okay, brilliant. All right, good. So with that done, let's discuss now what it means to cope with chronic pain. And just heads up, this is not a data presentation. It's not based on a study. Instead, I am attempting to create a sense of inquiry and self-reflection on how to take the meaning of coping with chronic pain and apply it in the clinic. And I do think that thinking about what we do and what the doing represents in the clinic can be rewarding. So with that in mind, let's start. So we're talking about the meaning of coping with chronic pain. So because we're talking about meaning, a good place to start is with language, because language, of course, is our premier means of articulating meaning to each other. So when we look at the origin of the word cope, the verb cope derives from the Latin, meaning a blow with the fist or a smack on the ear. By the mid-17th century in continental Europe, cope had the meaning to struggle or deal on fairly even terms or with some degree of success. Now, our modern meaning of the verb cope, which dates from the 1930s, broadened in scope to mean to manage or deal with responsibilities, problems, or difficulties successfully and calmly. So we can see from these three different meanings, the ancient meaning, the 17th century meaning, and our modern meaning, that there is continuity across those different meanings of the verb cope. But with the modern meaning, there's now added a new moral dimension linking coping with personal responsibility. So that's an interesting development. So today, the word cope commonly means response to threat, regardless of its success or failure of that coping response. And the coping response may be behavioral or cognitive in nature, or a combination of both. So now moving into the psychological literature, Lazarus and Folkman, 1980, writing about stress, narrowed this common meaning of coping by focusing on voluntary forms of responding. They define coping as effortful behavior, deliberately engaged in as a response to a stressor. So their definition is the cognitive and behavioral efforts made to master, tolerate, or reduce external and internal demands and conflicts among them. Looking now to the pain literature, you'll find that diverse terms are used interchangeably with coping with chronic pain, and these other terms include living with pain, pain management, managing pain, self-management, adapting to pain, dealing with pain, and adjusting to pain. So it's not clear from all of these synonyms to what extent these terms are in fact interchangeable with coping with chronic pain. For example, some people can self-manage their coping response to pain. Others are heavily dependent on others across time. So it's not clear from this abundance of terms if we are talking about the same thing, that is coping with chronic pain. So I think that is a potential issue for misunderstanding. So aligned with Lazarus and Folkman, with a focus on stress, we can say that chronic pain is a stressor. Primarily, it is threatening, intrusive, and distressing. But secondly, it interferes with the everyday tasks of life. It interferes with goal achievement and future planning. And finally, as a stressor, chronic pain provokes the related stresses of depression, anxiety, and identity confusion. So there's a lot to recommend. The definition of coping by Lazarus and Folkman, there is continuity between coping, stress, and the nature of chronic pain. So turning now to classifying coping in the psychological literature, the active versus passive coping distinction is often used to classify coping. In the pain field, this distinction is represented in the Vanderbilt Pain Management Inventory. Active coping refers to strategies used to control pain or to function despite pain. For example, using distraction strategies is one example of active coping. On the other hand, passive coping is related to withdrawing and surrendering control over pain. An obvious example might be taking medication to observe if the pain subsides. Another commonly used distinction in the literature is approach versus avoidance coping. Approach coping describes, pardon me, strategies of directly engaging with pain or its causes, whereas avoidance coping describes strategies of engaging efforts away from the pain. So there was a clear parallel here between active and passive coping. Another influential way of classifying coping strategies is between problem-focused and emotion-focused coping, as used, for example, in the daily pain coping inventory, shown here. Problem-focused coping directs attempts to deal with the pain or to directly solve the pain problem. For example, doing something specific to try to reduce the pain. By contrast, emotion-focused coping strategies deal with the emotional responses to the pain and the stress it evokes. For example, a person with pain might seek emotional support from loved ones, friends, or professionals concerning their pain. So that is the basic landscape in terms of classifying coping in the pain literature. So I think these distinctions lead to some assumptions that we can perhaps question. The first assumption made in the literature is that no one coping strategy has emerged as effective for all people with chronic pain all the time. There is evidence for beneficial and adverse effects on pain and patient functioning for many coping approaches. For example, attempting to control or find a solution for pain is linked with better patient functioning, but this approach may have negative consequences when actual control is difficult to achieve. While persistent attempts to stay physically active is considered adaptive for many people with chronic low back pain, task persistence undertaken with a come what may attitude has been identified as a risk factor for pain-related disability. So there is an assumption that active or problem-oriented coping strategies are adaptive, whereas passive or emotion-oriented coping strategies are maladaptive. But the point that I want to make here is that the effectiveness of a coping strategy depends on its effectiveness in the life of the individual. Based on abstract concepts such as active or passive, it's impossible to generalize effectiveness from groups to individual patients with pain. So let's look at some specific examples illustrating this point about the importance of context when it comes to understanding the meaning of coping with chronic pain. So question, resting or pacing as coping with chronic pain, are they effective? And the answer that I want to suggest is, well, it depends on the effectiveness of these strategies for the individual. So, for example, to elaborate on resting in more detail, if resting is the only coping strategy a person has, or if resting is the main strategy this person uses to cope with breakthrough pain, and if resting also interferes with this person's ability to be independent, then perhaps resting for this person is not an effective coping strategy. On the other hand, if this person has an array of different strategies to cope with her pain, for example, she uses resting, some medication, and regular moderate exercise, and if she's able to be independent and she can do the things that she wants to do, then resting for this particular person is an effective strategy. Turning to pacing, instead of pacing, there are times when an individual chooses to push beyond usual known limits to achieve certain personal goals. For example, persevering at a sporting activity or a gym class, even though it can increase pain, because of the benefits of these activities, such as excitement, achievement, which can be experienced with others, pacing may not be applicable in these particular circumstances at all times. Other considerations regarding modern conceptions of coping in the literature: some coping strategies don't work in the way they are intended to work. For example, in reality, it's really hard to manage chronic pain. It's super challenging. There are many times when, despite the best efforts of people to follow activity management principles, to manage stresses at home, or to think in helpful ways, pain ignores these attempts and fluctuates and worsens. And I think by focusing on efforts to change pain, healthcare professionals or caregivers can encourage people to constantly analyze what they've done wrong to exacerbate their pain. However, I think that by focusing on trying to change thinking, some people can end up judging themselves harshly for having the same sort of thoughts that all people have. In other words, these thoughts to change pain still occur despite our efforts to control the occurrence of these thoughts. My other concern with this is that some people who follow this approach about trying to think in helpful ways may become withdrawn because they are over-analyzing things. They can become sensitized to, they continually monitor and become preoccupied with pain or other bodily sensations, which to them might signal impending pain or even advancing disease. So this hypersensitivity to pain might lead to panic or overreaction in some patients, in some people with pain, sorry. So perhaps it's more important to investigate how much attention to pay to certain thoughts or how to learn to let them go or learn to live with them in order to focus on what the person wants to do. I think we need to exert greater thought and attention to the effectiveness of various types of coping with pain, when they might be helpful or useful and when they might not be in the life of individuals. So this lived knowledge could supplement research-based dichotomies in clinical decision-making. So we might consider studying people who cope well with pain and identify the strategies that these people use and when. So coping well, how do people who cope well deal with chronic pain in their lives? And the answer is people who cope well with pain use anything and everything. They use anything that works, basically. Many people who cope well with chronic pain do not focus their coping effort entirely on the pain. In fact, some people will not even mention pain as their coping focus. Instead, by using anything that works for me, they can do what is important to them. So they judge a coping strategy based on how well it helps them to do what they view as important in life or meaningful. This suggests that people who cope well with chronic pain can focus their efforts more on what gives their life meaning and less on alleviation of pain alone. And of course, this is a big part of acceptance and commitment therapy, or ACT. So how about coping with pain over time? Well, over the life of a person with chronic pain, coping strategies can change. Not only do some ways of coping become easier, other strategies can become redundant because they no longer work. Others are adapted or transformed. It's not clear whether people use the same strategies for the same reasons as they progress through the lifetime of their pain. I think more research is needed here. Further, it might make sense to use medications in the earlier stages of a pain problem, but choose to discontinue with these later on. Another example, selective use of rest might be appropriate during the early stages of coping with rheumatoid arthritis, but selective use of rest might make less sense as time goes on. Coping strategies most likely to become adapted or transformed could be the cognitive ones, or the beliefs and expectations about what gets done and how it gets done. These beliefs and expectations develop from our underlying values, and maybe changes in our underlying values is one driver of change in cognitive coping strategies. I think more research is needed to demonstrate if a link exists there. So older adults can help us understand how people with chronic pain cope across the lifespan. Some older adults allow themselves more time to perform the activities of daily life. They make that mental adjustment. They make changes to the ways in which they perform activities so that they can remain as active for as long as possible. Many try to maintain their independence and learn new skills. Older adults want to have some knowledge about their pain diagnosis, and they also want to learn about methods of coping. And many want to be involved in shared treatment decision-making. More broadly, they want to be involved in the world. Thirdly, which is really our focus here today, many older adults use different strategies to cope with pain, including exercise, task persistence, postural changes, pacing, rest, distraction, medication, reporting pain to others is especially important, and relaxation. Older adults prefer self-administered and home-based coping strategies. Their main aim is to carry on with valued personal activities or goals. Finally, older adults find meaning in their lived situation. Many hope for a recovery. They adopt a positive attitude. They try to understand the pain. They also, especially men, try not to make excuses. They try to keep going despite the pain. Self-efficacy is widely considered important by older adults. Some are concerned about not being understood by others, a decline in their condition, or some worry about a loss of independence. So now, wrapping up the previous and considering implications for other people other than the person in pain. So thinking about others, the context sensitivity of coping with pain means that healthcare professionals and caregivers take time to understand why, when, where, and how people with pain do the activities that are important to them. I think that's critically important. If people with pain don't know how to do what's important to them, or if they only have a few coping strategies to choose from, or if they are worried because the one strategy they use becomes an obstacle to doing what they want to do, then their coping strategies could be ineffective. So that would be important to know. Another consequence is that using a coping strategy inventory, such as the Vanderbilt Pain Management Inventory, might not be a good way to decide if a person needs help developing coping strategies. Instead, healthcare professionals might choose, for example, the chronic pain coping inventory to identify a range of strategies an individual knows about, instead of whether the strategies they use are passive or active, and so on. To measure whether currently used strategies are working for people with pain, a disability outcome measure such as the Roland Morris Disability Questionnaire or the Canadian Occupational Performance Measure could be suitable. Looking at the Roland Morris questionnaire, this is designed to assess self-rated physical disability caused by low back pain. It is most sensitive for patients with mild to moderate disability due to acute, subacute, or chronic low back pain. By contrast, the Canadian Occupational Performance Measure is designed to capture a patient's self-perception of performance in everyday living over time. So I think this measure in particular is well suited to assessing psychosocial adjustment over time. And what I like especially about the Canadian measure is that it is an open dialogue between client and therapist, or between patient and therapist, each party bringing their own expertise and perspective to the conversation. And I think this flexibility allows the therapist leeway to ensure the tool works best for the lived situation. So I think this Canadian measure is well suited to assessing the context sensitivity of coping with chronic pain. Okay, so by way of conclusion, I have tried to argue for the effectiveness of a coping strategy is reliant on its effectiveness in the life of the individual. People who cope well with pain use anything and everything, and I think increasingly we can turn to such individuals as models for what it means to cope well with chronic pain. And these people focus their coping efforts more on what gives their life meaning than on alleviating pain alone. And finally, perhaps a baseline question for all of us: why, when, where, and how do people with pain do the activities that are important to them? Okay, thank you very much for listening, guys. That is the end of my presentation.
Thank you, Simon. I will just stop the recording.